Okay, we're going to go over, I'll give you a brief lecture here on cognitive behavior therapy. I'm going to try to fit at least, hopefully, two different PowerPoints in over the next couple of days here with relatively short lectures. And beyond that, the plan for the remaining semester really doesn't change a whole lot. I'm going to try to cover the material that is listed in the syllabus. This has been complicated a little bit here recently by all the virus precautions and of course working in a medical clinic. Things have been a little more complicated at this end than we were expecting, so there's been a little bit of a delay in some of these, but I think I should be able to get this one here done today, maybe the next lecture done tomorrow or the next day, and then hopefully I'll post two more next week. I would like to have all of the lectures for the remaining part of the semester done here in the next couple of weeks, so you guys have them, have your PowerPoints, and obviously have the text materials to go over well in advance of the final exam. And then what I'll probably do is open the final exam. The final exam will be on Moodle. We'll open it and leave it open for the better part of final exam week. I'll probably close it a day before the end of final exam week, simply so that I can have some time to post grade, get everything graded, get everything added up and posted. So with that being said, let's jump in. We'll talk about cognitive behavior therapy. I'm going to be very efficient. I hope to keep this to no more than an hour for your benefit. Be sure you're reviewing the PowerPoints. Be sure you're reading the texts for the exam. If you have questions about the material, send me an email if we need to talk over the phone or via Skype or something similar to that. We can definitely do that. All right, here we go. So talking about cognitive behavior therapy, certainly the most widely used psychotherapy intervention in the modern age. I would say take that with a little bit of a grain of salt. Cognitive behavior therapy is probably legitimately the most commonly used approach. You'd have to say that, though, with the caveat that most modern psychotherapists would describe themselves as cognitive behavioral, but if you actually sit and look at their practice, a couple of things stand out. One, we've already talked about the fact that the common factors piece is broadly appreciated and has been implemented across most psychotherapy approaches. So the cognitive behavioral perspective has incorporated certainly humanism. It is also has also incorporated many of the valuable, more useful contributions and observations from psychodynamic approaches, existential approaches. So, and that isn't a criticism of cognitive behavior therapy. That's good. You want in any professional approach. I think it was Bruce Lee who talked about this. He when asked a question about various martial arts, he basically pointed out, I don't remember the exact quote, but essentially steal from each art what's useful and get rid of the rest. And what we have seen in cognitive behavioral therapy, which is essentially at this point the therapy that has resulted from people looking at different intervention techniques, different approaches in a research setting, and determining what there is research support for in terms of efficacy. So cognitive behavior therapy, maybe a shorter way of saying all this, cognitive behavior therapy has quite a large umbrella at this point. There is pretty solid empirical grounding, and part of that is because the therapeutic approach itself, the cognitive behavioral therapy, essentially came from university settings, in no small part because you had people who started out in university settings doing research as behavioral or as learning theorists. They went to apply their learning theory, and in the course of kind of pragmatic efforts to help people, began to, well, certainly they were influenced by the work of Carl Rogers and the other humanists, began to recognize the reality in psychotherapy that what is going on in the so-called black box, what's going on internally for the person in terms of emotion and cognition, are indeed important. They may be more difficult to research in a laboratory setting, but in practical terms, where you're trying to help somebody with psychotherapy, they're indispensable. And so as you had these university-based learning theorists trying to use what they knew to help people, you got this gradual transition toward more exploration of the cognitive and emotional components that eventually comprised cognitive behavior therapy. When we talk about CBT, cognitive behavior therapy, it can be distinguished from what we spent the first part of the semester talking about in terms of humanistic approaches, existential approaches, psychodynamic approaches, in that it tends to be more problem focused. In other words, much of CBT is kind of centered around, let's identify a specific problem for which we have a particular set of interventions that we know works. The other, as opposed to psychodynamic psychotherapy, which is not infrequently the focus of treatment in psychodynamic psychotherapy is the facilitation of insight. That we want the person to understand themselves generally, as opposed to CBT, where what they're going to be doing in the initial interview is looking at where specifically is the problem. Let's make that the focus of what we're doing and get in and out as quickly as is reasonable. So not a bad thing. The other way in which CBT distinguishes itself from dynamic, humanistic, and existential approaches is it does tend to be a little more directive. The CBT therapist is a little more likely to give explicit instruction or advice. Of course, in this case, advice is not, oh, you should dump him, to somebody who's having problems with a boyfriend, or but more along the lines of psychoeducation. So the advice is more centered around, here is what research tells us, or here is what we know on the basis of research. Therefore, I can recommend this path to you or that path to you. So it's not opinion giving, it's provision of education based on research. So you get that piece of it more frequently. CBT definitely includes as a strong component the provision of psychoeducation. We're going to talk about all this in a little more detail here in a second. It also includes, like behavior therapy does, explicit prescription of certain behaviors, practices, homework, that sort of thing, which distinguishes CBT from, certainly from traditional psychoanalytic approaches, and even from psychodynamic and existential approaches, which tend to be less frequently comfortable with explicit instruction, explicit prescription of homework, and that sort of thing. The two big names that you hear associated with CBT are Beck and Ellis. Earlier in the semester, when we were going over the paperwork that you generally use, especially in the first session of psychotherapy, I showed you a Beck depression inventory, and I think a Beck anxiety inventory also. That's the same Beck. Aaron Beck is the guy who came up with those inventories, those self-report measures, and they were to facilitate his approach to cognitive behavior therapy. He was looking at directly addressing the symptoms of depression, directly addressing the sleep disruption, addressing the appetite disruption, addressing the irritability, the moodiness, these kind of things. So he was introducing interventions intended to change those specific things, and then he, at each meeting, would have somebody complete these inventories, like in this case, the Beck depression inventory, to see, are we making any progress? And his initial implementation, or his initial development of what was to become CBT was originally intended to address depression. It was essentially, okay, what do we know? What do we know in research actually can help? What do we know about depression, and what do we know can help depression? And let's implement that very methodically. Since then, CBT, which is again essentially, here are the techniques that we have good and a good empirical basis for implementing to treat whatever psychological disorder. CBT has expanded to address essentially, I would say, virtually every psychological condition that is amenable to psychotherapy. And as I mentioned to you when we were talking about behavior therapy, while dialectical behavior therapy was presented as a behavior therapy, it is probably a better fit with, better thought of as a cognitive behavioral therapy approach. One other thing I want to make sure I mention to you is research you may have seen indicating, you may have seen research that indicates that psychotropics, psych meds, work quite well, as well as psychotherapy, and also the converse of that psychotherapy works quite well as the prescription of psych meds, SSRIs, anti-anxiety agents, that kind of thing. We know how to say this succinctly. This is the long and the short of it. We know psychotropics work. We know psych meds work and work very well. We know psychotherapy works and works very well as the meds do. The other thing we have found, though, is that a combination of the two, of medicine and psychotherapy, works better than what you would expect would be the cumulative effect of both of them independently. So you get this kind of, I can't think of the word, they feed each other, essentially. If you get a 50% benefit, or let's say you get a 40% benefit from psychotherapy and a 40% benefit from psychotropic medication, to address whatever the condition is, you would expect that using the two of them together would give you an 80% benefit. In fact, what we find is that the benefit even extends beyond that. They work better together than either one of them does alone, or both of them would alone. So the reason I'm saying this to you is that if you find yourself wrestling with depression or anxiety or any other significant psychological problem, and you're willing to accept help, give serious thought to not just doing psychotherapy or not just talking to the doctor about trying an SSRI, say, for example. But if you're going to do either of them, try both. Try both of them together, because they do tend to work significantly better in conjunction with one another. So what does the actual approach look like? CBT tends to be focused in the what they call the here and now. In other words, you're likely to hear from a cognitive behavioral therapist some, I don't want to say dismissal. The emphasis in cognitive behavior therapy is on what is the problem currently, how is it currently and recently affecting your life, your relationships, how are you feeling and thinking currently, recently, as opposed to the kind of the deterministic causal sort of perspective that you tend to find in psychodynamic and psychoanalytic psychotherapies, where there's discussion in the pursuit of insight about how did you get to where you are, what caused this, how did you what happened during childhood, what experiences have you had that have created the current circumstances. One of the things that we see here more recently, though, is that especially with relational psychodynamic psychotherapies, where the psychodynamic psychotherapy is kind of focused on the transference as a way of helping the patient address the problems, especially relational problems that brought him in. When you have somebody doing that kind of psychodynamic psychotherapy, you get a focus much more like cognitive behavior therapy on what's going on right now in this room between the two of us. And in some psychodynamic psychotherapies, especially when the problem is a relationship problem, there will be more discussion in that CBT of what's going on between us right now. But it's also a focus on current behaviors, such as how are you sleeping, how are you eating, are you exercising, are you, what does your social behavior look like, et cetera, et cetera. And we'll talk about why that is here in just a minute. The other thing that characterizes cognitive behavior therapy is that the focus tends to be much more on practical, concrete specifics. Again, how many hours did you sleep last night? What time did you go to bed? What time did you get up? How long did you spend awake in the middle of the night? Did you use anything to help you sleep? Same kind of questions about appetite and eating patterns, exercising, implementation of homework. If somebody comes in and they have multiple failed dating relationships, rather than talking in terms of abstract generalities about the way the person experiences or thinks about the other sex, as opposed to thinking about and talking about experiences in adolescence and in early childhood. The cognitive behavior therapist might be focused on role playing with the patient. When you meet somebody new, how do you approach them? How do you talk to them? It might be focused on social skills teaching, getting the person better at making small talk. In some cases, even helping the person become a little more efficient at flirtatious behavior, appropriately flirtatious behavior. Working on the person's capacity for assertiveness, these kinds of things. So they're very, let's fix the concrete behaviors, the things that are actually the interactions themselves. And if we fix the idea being that, one of the ideas being that if we fix the interactions themselves, this is the behavioral part, that the overall situation and certainly your emotional and cognitive response to the situation will improve. The CBT approach in this regard is very, very much problem focused and solution focused. You have from that behavioral, the behavioral origins, learning theory origins of cognitive behavioral therapy. You'll not infrequently have some degree of analysis of what specifically is the problem, operationally defining the problem, the context in which the problem occurs, et cetera, and then working very directly and very concretely to identify solutions, helping the person practice behaviors that are incompatible with a problem behavior, say, for example. Again, providing training to shore up areas of weakness that are contributing to problem areas, these kinds of things. And I'm going to give you some examples of this kind of stuff as we go along today. And then, of course, the other way in which CBT is relatively unique, especially compared to some cognitive behavioral, humanistic, and existential approaches, is that it does tend to be fairly explicitly time limited. It isn't unusual for a cognitive behavioral therapy approach to have a specific prescribed number of sessions, and to have the sessions, the content of the sessions or the agenda for the sessions, say, I'll give you an example. One of the cognitive behavioral approaches that they use in the VA for treating PTSD is a once weekly 12-session approach, where everything from the first session to the 12th session is laid out fairly specifically. Not that there can't be deviation from the agenda if it's warranted, but they have an approach that has been well demonstrated in research as being effective in reducing the intensity of symptoms of PTSD. So they know going in that they're anticipating we're going to have, in 3 months, one session a week for 12 sessions, 3 months, we will have addressed this problem. You will have improved functioning, et cetera, et cetera. That, real quick, another thing about the time-limited piece of it. One of the nice things about that approach, one of the things that we know, I may have mentioned this earlier in the semester, sometimes having an open-ended psychotherapy, in other words, a psychotherapy where we don't have a specific assigned conclusion to the therapy, there's no pressure. Think about it like this. You may be facing this right now. You are more likely to apply yourself in your studying, writing, whatever, if there's a defined due date. If there's, the exam is this day, the paper is due this day. that focuses the concentration, it focuses the attention. You have some sense of some degree of, I don't want to say time pressure, but you have some sense of, I need to get things done by this time. And there are situations where, in fact, I would say in most situations, having that sense of we're going to start here, we're going to be done here, we're going to address this particular problem, and we're going to do it in a very orderly and kind of pragmatic way, does tend to focus the individual, as opposed to if you don't have a limited duration for the psychotherapy, you can find yourself inadvertently talking about all sorts of things that may or may not actually contribute to the person feeling better, exploring all sorts of parts of their lives that may not that they're unimportant, but that they're not pertinent specifically to the problem that brought them in. Limiting the time that you have available to you can tend to have a beneficial approach beneficial effect in terms of focusing the attention. And the reality is that in this day and age with managed care, insurance payment, you need to be able to justify every session, and you need to be able to have some plan for how long is this intervention, this psychotherapy, going to take to produce some benefit. So CBT, focused on the here and now, on the concrete rather than the abstract, tends to be structured, planned out, time limited, and then very pragmatic in terms of being problem focused and solution focused. So I've already kind of spoken to a little bit of this. With cognitive behavior therapy, you tend to see more explicit action from the therapist. The therapist tends to take a more active role in, well, let's see here. Say you have somebody who comes in to see the therapist. They come in for the classic picture. They come in for symptoms of depression, and one of the things that we know that perhaps at this point in the semester is getting to be old hat to you, and sounds like a broken record, but the reality is that we know that if somebody is having problems with depression, if we address sleep problems, improve their diet, and get them exercising on a daily basis, the symptoms of depression are going to improve and may resolve completely. So in a cognitive behavioral approach, especially early on, the cognitive behavior therapist may be very focused on teaching sleep hygiene, tracking the person's actual sleep behavior, tracking the person's actual food consumption, not just how are you eating, but actually giving the person, in some cases actually a food journal, and having them track how much am I eating, what am I eating, how much am I drinking, what kinds of things am I drinking, am I drinking alcohol, am I drinking sugary drinks, how much snacking am I doing, these kind of things, not just what they're eating at their meals, but what they're eating in between meals. Not just asking the person how many hours a night are you sleeping, but actually recording when did I go to bed, how long approximately did it take me to fall asleep, how many times did I wake up in the middle of the night, what time was I supposed to get up, what time did I actually get up, am I tired, sleepy, low energy during the day, am I having problems with motivation during the day, am I napping during the day, these kinds of things. And then the therapist the cognitive behavioral therapist likely is giving very explicit instructions in terms of what they want the patient to do throughout the day. Almost in some cases acting like a cheerleader, or a disciplinarian perhaps, strongly discouraging, say, for example, we know 8 hours of sleep a night, not napping during the daytime, getting out, moving around, tracking how much, because we're asking the person to document it, that's part of their homework. What kind of exercise did you do Monday, Tuesday, Wednesday, Thursday, Friday of last week? How long did you spend doing it? What days were you unable to get yourself to exercise? Or what that probably wouldn't be how I would phrase it in cognitive behavior therapy. On what days did you not exercise? And what other things took place or didn't take place on those days? And we're looking for patterns there. If we find out that the person slept poorly the night before and so didn't exercise the next day, we would start looking at, okay, what did you do differently that night, especially if their sleep has recently been improved? What did you do differently the night before? Is there anything that we can identify that we can get you doing that works for you in terms of promoting sleep? So not that you would never see this kind of thing in existential or psychodynamic approaches, and especially modern approaches, you are likely to see these kinds of things because they've taken from CBT what works. But in CBT, this is the approach, is that we're coaching and teaching, in part of CBT is coaching and teaching these strategies that we know in this case, will counter the symptoms of depression. While we avoid giving advice, kind of like what I alluded to before, in terms of giving, if somebody comes in with depression, and part of the depression is that they're socially isolated, not unusual, they've kind of withdrawn. What a CBT person or any therapist wouldn't do is, oh, honey, you need to go on a date, or, you need to find yourself a boyfriend or a girlfriend. That's kind of along the lines of advice. On the other hand, saying to the person, providing education to the person that we know increasing social activity tends to reduce the intensity and the duration of depression. We know it. No doubt, the evidence is very, very strong. And then exploring with the patient, what are they doing? What interferes with them getting out socially? When they have gotten out socially previously, what was the context? What worked for them? What didn't work for them? What's getting in the way now, and how can we address that sort of thing? What do you want to do? What would you like to be doing that you're not doing? Et cetera, right? In some cases, we're using, not infrequently with CBT, you use Socratic questioning to kind of help guide the person, help the person identify for themselves what the solutions might be. That's part of what I was alluding to before when I was talking about looking into the kinds of things that have worked previously, the things that have not worked previously, the kinds of things that the patient is telling themselves or not telling themselves that leads to neglect of behaviors that they should be doing and engagement in things that are problematic. The CBT therapist is going to generally be assigning homework every session, and it does tend to include things like, person comes in for depression. We are going to be tracking sleep hygiene, their actual sleep patterns, trying to improve their dietary practices, trying to make sure they're getting some physical activity during the day, trying to improve the consistency of their social outings, trying to make sure that they're engaging in social outings that are likely to reduce the intensity and frequency of depressive symptoms. In other words, not all social outings are created equal, right? If you're depressed and you go out drinking with your friends and you wake up with a hangover, that's probably not going to help the depression. On the other hand, if you're depressed and you meet up with some friends to go for a hike, that likely is, all things being equal, likely is going to help the depression. So we might be assigning homework, likely will be assigning homework specifically intended to counter the symptoms, or reduce the intensity and the duration of the symptoms that we're trying to address. We might be doing things like, if somebody's depressed and we know part of the problem is social withdrawal and some degree of social anxiety, that we will begin to do some basic social skills training, that we will begin to talk to them about implementing at first very simple and limited duration sorts of social outings, and building toward developing for the person a social network. So this might be things like, for somebody who's not completely agoraphobic and paralyzed with social anxiety, somebody who's relatively normal but has become socially withdrawn recently because of lack of motivation and dysphoria associated with depression. Perhaps what we would do is get them to identify 2 or 3 friends that they regard as supportive and that they enjoy being around, and we might assign as homework a phone call to them to set up a social outing. And for a person who's really become immobile because of depression, we might actually rehearse it with them. We might actually go over, okay, so when will you call this person? And if you don't pick up the phone, when will you call them back? What will you say if you leave a message? Once you get the person on the phone, what are you going to ask them to do? How will you set it up? So what we're trying to do is we're trying to knock down obstacles, excuses, and that sort of thing, and we're trying to elicit from the patient a commitment to do these things. And we may actually role model or role play, say, the phone call, to address problems that might come up, obstacles that might come up. And then the other thing that we're doing, as in the course of doing cognitive behavior therapy, and this is definitely a big piece of it, is confronting faulty beliefs. For somebody who's depressed, the faulty belief might be nobody loves me, nobody likes me, nobody wants to be around me. And we might use, like I said before, we might use that Socratic questioning to help counter this. Has it always been like this? Well, no, I used to have friends. Well, how long ago did you have friends? Exploring things like, what have they said to you that gives you the impression that they don't care? Have they said anything or done anything that is inconsistent with that impression that they don't care? What we're looking for evidence, basically, that the person actually does have friends and people do care about them. They do have family members that care about them, this sort of thing. And that we're exploring methodically the evidence in support of and against these things that we assume are faulty beliefs on the part of the patient. So you can see that the cognitive behavior approach is built on the idea that the patient is going to assume an active role in identifying and implementing solutions to the problems that they have. It doesn't work. The cognitive behavior therapy does not work unless the person actually accepts responsibility for completing the things that you're recommending to them. To continue with the example that I was giving you before, a cognitive behavioral approach to treating depression. One of the things that we're doing early on is we're asking the person to agree to take responsibility for implementing these things that we're teaching them. We're talking to them about the basic 3, that if you sleep well, eat right, and exercise daily, you're going to feel better, and getting a commitment from them that they're going to work hard to implement this. And then giving them assignments and having them agree that I'm going to complete this assignment before I see you the next time. And then we're also, if the person, regardless of whether the person actually does it or not, we're asking them to accept responsibility for their own behavior, in terms of the homework, in terms of the things we're asking them to do. And we're asking them to be accountable. If they don't do it, well, what happened? How can we address this? And this is not an aggressive sort of an approach where we're blaming or berating or criticizing the person for not doing the things that they agree to, but basically we're wanting to get a buy-in from them that they are actually going to exert a significant effort to implement the things that we're recommending to them, because this is an active approach. And without that action, the likelihood of improvement is very small. And so we're approaching this from the perspective of, if for some reason, say the person's going to walk for half an hour each day of the week, in the week between this appointment and next, and they get to the next appointment and they say, well, I only did it 3 days in a week. Well, we're not going to chew them out for not doing it. We're going to reinforce and praise the 4 days, say the 7 days that they walked 4 days out of 7. Okay, well, we're going to encourage them and give them credit for getting themselves out there and walking those 4 days. We're going to look at what was going on those days, what was different about the days where you did exercise from the days where you didn't exercise, both in terms of, are there things that perhaps contributed to you actually getting out and implementing this thing that you intended to implement? Are there things that interfered with it? Also, what were the consequences? Did you feel better? And generally people do. If they go out and they walk for half an hour, they generally feel better that day. What was different? Were you less irritable? Were you less tired? Which is generally the case if you go walk for half an hour. Did you sleep better that night? How was your appetite? Was it easier to control the urges to do late night, kind of comfort eating, snack eating, that sort of thing? We would go through step by step by step. And of course, we're looking for things that are going to reinforce desirable behavior and diminish the likelihood of undesirable behavior. And we're wanting a buy-in from them in terms of identifying these things and then taking action to make changes so that they actually engage in the behaviors, the practices that are going to address the symptom, the problem behaviors, the symptoms and such. We're also going to spend a considerable amount of time in cognitive behavior therapy working with the patient to understand their what we call their core beliefs or their schemas. We want, as therapists, we want to understand, and we want to help the person understand how they're thinking about themselves, the world, the people around them, and to what degree are these ways of thinking, these schemas, accurate, and how much of, and to what degree are they problematic? Are they inaccurate or unrealistic? Everybody hates me. That's a schema. That's a way that they're thinking about the world. And the reality is, in the vast majority of cases, it's false. And so one of the things we want to do is we want to identify that, make the person cognizant of the fact that they're telling themselves that this is the way they think about the world, and then helping them confront the belief as almost certainly false, right? The reality is, everyone is never, the statement, everyone does X, or everyone thinks X, or everyone whatever, is never true. It's just not true. You can't make those kinds of statements about the world and expect them to be reliable. So helping the person identify the ways in which these schemas that are causing problems for them, these core beliefs that are causing problems for them, are false, and then replacing the faulty parts of the core belief with more productive schemas, with more productive pictures of the world around them. So everybody hates me. Going through it and helping the person identify, no, not everybody hates me. There are some people actually who do care about me. These are who they are. This is the quality of those relationships. This is how I'm different with the people who care about me than I am with other people who I think don't like me. There are people who don't like me, and coming to some conclusion about, are there things specifically that are legitimate things that they don't like about me, and how can we change those things? Do we want to change those things? That would be actually a better question to start with. And so methodically going through, again, using Socratic questioning, having the person identify for themselves, to kind of track down what is false about these beliefs, what's accurate about these beliefs, and how do I go about changing the ineffective, false, problematic components of these schemas, and then having the patient take responsibility for new approaches, new ways of interacting, and then helping them to develop the skills necessary for them to take these new approaches. Okay, so the underlying principles for CBT are pretty straightforward. The idea here is that cognition, thought processes, affect behavior and emotion. And then conversely, behavior affects thoughts and feelings affect thought and behavior. CBT is asserting that we can be aware of our thoughts and that we can monitor and change them, and that when you begin to change the way a person thinks about the world, you increase the likelihood of behavior change and modification of emotional experience, change in emotional experience. Putting this slightly differently, as I said a second ago, how you think affects how you behave and how you feel affects how you think and how you behave, and whatever the third leg of that is, I forget which way I started. I think I have probably mentioned this to you previously in this class, or if not in this class, during the previous semester when we talked about personality theory. But one of the truisms and one of the things that makes psychotherapy so vital is that, unfortunately, we don't get to choose how we feel. Feelings are things that happen to us, that we're often afflicted with, especially negative feelings. Unfortunately, we don't get to choose them. We can't choose to stop feeling a particular way. We can, however, to a fairly significant degree, choose certain behaviors. You can choose to stand up or not stand up. You can choose to eat a particular food or not eat a particular food, to attend class or not attend class, study or not study. And I'm not discounting that these aren't always easy things to control, but you do have some capacity for control over them. And similarly, you do have some capacity to elicit some control over the direction and content of your thoughts. I can suggest to you to count in your head to 10, and you can make that happen. You can choose to think that. We can, while we may not always have an easy time convincing ourselves or controlling ourselves not to think of something, it's the old don't think of a pink elephant thing, we can relatively easily choose to think about things that are incongruent with something that we want to avoid. So if you're dieting and you get thinking about the package of Oreos that's in the cabinet, a CBT person might suggest that you picture in your head, or maybe you go online and you get on the web page of somebody who you admire in terms of their body composition, and you look and focus on the way I want to look in a month or 2 months, or perhaps instead of that you focus your mind on what you're going to cook for dinner and choosing ingredients and such as a way of distracting yourself from the temptation of the Oreos. So we can, to some degree, choose, influence our thoughts and our behavior to a degree generally more significant than we can with our emotions. And that's certainly, I think I would say that's the premise of much psychotherapy. It is the basis for cognitive behavioral therapy. If we can control, if we can help a person change their thinking and their behavior, emotions will follow. And this effort to help the patient shape, manage the course of their thinking, the direction and content of their thinking, is based on an assumption made in cognitive behavior therapy that emotional distress and psychological dysfunction is frequently the result of automatic, erroneous beliefs. So these are the beliefs that underlie the schema, the picture of the world that we carry around inside of us. And the automatic piece of this is important because this is part of the focus of psychotherapy. The assumption is that we each walk around with beliefs about the world that have been there for so long and are so much kind of part of our makeup that we don't even recognize that they exist often. Somebody who is, say, raised in an abusive and neglectful environment may operate with an expectation or an assumption, an automatic erroneous belief that the people of the world are generally malicious beings. And I think that this is fairly demonstrably false. There are malicious people out there, but the average person walking the street doesn't have personal hostility directed towards you. There might be somebody who does have that, but the average person out there, the typical person that you randomly interact with in the grocery store, at work, that sort of thing, generally does not carry that kind of animosity towards you. So we're operating on the presumption that's probably an erroneous belief. And we're recognizing that somebody who's been raised in an environment, say from early childhood, where the people around them were at best neglectful and in some cases actually malicious and abusive, the person may have become so conditioned by that environment that they don't even necessarily recognize that assumption of maliciousness. It's just a fact about the world. It's the old the thing on the slide there, a fish not noticing the water it swims in. And in fact, if you sometimes in cognitive behavioral therapy, when you begin to approach one of these erroneous beliefs, you get some big pushback from the patient because the patient, in some cases, like as in this example case, may very well struggle to recognize the irrational content. They're so used to seeing the world through that particular lens, everybody is malicious, that their capacity for thinking otherwise is limited, and they have to do considerable practice and considerable talking through. And this is part of where that Socratic method comes in, trying to find exceptions to the rule, say. Identifying evidence that there are exceptions to the rule, these kinds of things. And we're making an assumption in cognitive behavior therapy that these erroneous thoughts ultimately, in being erroneous, are irrational. And that if we take the time to methodically work our way through them and look, kind of basically take the thought and turn it and examine it from all sides together with the patient, and ask the patient questions about it and explore the erroneous thought with the patient and have the patient account for the implications of the erroneous thought. That in doing this, in that Socratic method, that we can help the patient begin to see the gaps, begin to see the inconsistencies in their assumptions. And we can do some basic psychoeducation by helping them understand, say, for example, in the example that I'm giving you, that it, it would be very understandable for somebody who is raised in an abusive and neglectful environment, because that gets kind of almost like encoded early on, to see behaviors from others that could be potentially interpreted otherwise, seen through the lens of malice, right? So the person who's raised in that environment and whose automatic erroneous thought is that the world is malicious, people are by default malicious. They're driving along in their car and they got somebody tailgating them, and that person, in fact, is tailgating them only because they're driving 5 miles an hour below the speed limit, and the person behind them needs to get to work and they're late. And it has nothing to do with maliciousness. It might be a little self-centered, but not malicious. But the person that we're dealing with in our example struggles to step outside of this mindset that has become so automatic for them, and may need to kind of work through the reasoning, the faulty as it may be, behind the automatic assumption that the tailgater is malicious. This is personal. This is intentional. So automatic erroneous beliefs underlying and coloring basically the schemas that characterize our perception of the world. And if you can change those erroneous beliefs and change the schemas, what ends up happening is you begin to see the world differently. I'll give you a real quick example. I think I may have talked about this because it's a pretty common sort of a thing that we do in psychotherapy. Somebody who, I'll have patients sometimes who had been wounded in combat, and they carry with them long-term consequences of being wounded. They have some sort of physical problems as a result. And they'll see themselves oftentimes as profoundly unlucky, they had the extreme bad fortune to have been in this particular place at this particular time and had been wounded. And there's some truth to that. But you can one of the cognitive behavioral techniques that we use fairly frequently in psychotherapy is something we call reframing. So it's basically taking something like this and it's saying, you can look at it from that perspective, but let's turn the whole thing around. Let's look at it from the other side. And in this case, taking the perception that wow, I'm profoundly unlucky because I was in this particular time in a particular place, and I got blown up, and I was wounded, and I have a damaged leg because of it. Say, the reframing might be, and I've actually had this comment to a number of men: you're a hard man to kill. How easily it could have gone even worse. And often, especially when the people who were in Iraq and Afghanistan, it did go worse for some of the people that they served with. Talking to somebody and they were injured, their knee was injured, say, in a IED explosion that killed some of the men they served with, and they see themselves as profoundly unlucky and unfortunate. And they might not have ever taken a step back and thought, I could so easily no longer be here. Had I taken one more step forward before that IED blew, I wouldn't be alive anymore. And helping them recognize that this default way of looking at the world, and one of the things we know about PTSD, this is one of the this line of reasoning often comes up with PTSD. We know people are more susceptible to PTSD when they come from abusive and neglectful backgrounds. It's like the table is being set to make them vulnerable to PTSD. So you get these people and something bad happens to them in combat, and their default is to see it from the perspective of, oh, this bad thing, oh, woe is me, here's another bad thing that happened to me, rather than the converse of that, man, I got lucky. Boy, it could have been worse. Okay. These negative thoughts that we these erroneous automatic beliefs that we're talking about here, we conceptualize them, if you're doing cognitive behavioral therapy, as being centered around what we call the cognitive triad. And generally what you find with these erroneous automatic beliefs is that they aren't unidimensional. They aren't just about us. Generally, say for example that maliciousness idea that I was talking to you about a second ago. The person who walks, abusive and neglectful background, they walk around daily with the perception that the world at large and people in particular, almost without fail or entirely without fail, are malicious. So we're talking here about the second leg, so to speak, of that cognitive triad, the second corner of it, the erroneous belief about the world around them, about other people. But when you have that erroneous belief, the world and people are malicious, it's accompanied inevitably by two more corners, two more pieces of that triad, and that is the self-perception, the erroneous self-perception that I am incredibly vulnerable, usually more vulnerable than the person actually believes they are, or more helpless, or an easier target, those kinds of things. And that the future is negative. The bad things are going to happen in the future. So you tend to see this triad, these three things that characterize erroneous automatic beliefs, that they involve an erroneous belief about ourselves, about the world around us and other people, and about the future. And that you have to deal with all three legs of that triad if you're really going to put the erroneous beliefs to bed, so to speak, if you're going to really address them. I'll give you a couple of examples here real quick. With anxiety, the triad that we generally see is an automatic, erroneous negative belief about the self. I cannot protect myself. An erroneous automatic negative belief about the world, that people will persecute me, humiliate me, threaten me, be hostile and aggressive toward me. And a negative belief about the future, that it's just a matter of time before something bad happens to me. Now, bear in mind what we're talking about here in the case of anxiety. There's some truth to all these things, right? You do have a limited capacity to protect yourself. There are some people out there who are hostile, aggressive, unpleasant people. In the future, it is a matter of time before something bad happens. Bad things do happen, and they will happen to you in your future. But they aren't the inevitability that this negative triad tends to convince the person that they are. And then the cognitive triad, the three components of this erroneous belief that underlies depression are that I'm unlovable, that others don't care about me, and that I'm going to eventually be abandoned or rejected by the people that I care about, by the world at large, right? And each category of cognitive or of psychological dysfunction, each diagnosis has kind of a characteristic cognitive triad that's associated with it. And the cognitive behavioral approaches for obsessive compulsive disorder, which is a subset of anxiety, PTSD, depression, ADHD, these kinds of things, all the the cognitive behavioral approach is based on what is the cognitive triad underlying, the particulars of the cognitive triad underlying that erroneous automatic belief. And then basically what's happening, say in the case of anxiety, when you have somebody who has that cognitive triad, well, one of the treatment approach is based in part then on countering these things. Well, one, using various techniques to help the person recognize that at least the extent of the way that they're thinking about these things is untrue. You're not completely unable to help to protect yourself. And we're not just telling them this. We're using Socratic questioning and other techniques like that to walk them through, to get them to think it through and recognize for themselves that these things are not absolutes. I do have the capacity to protect myself to some degree and can develop that further. While the world does have hostile, malicious people in it, not everybody is like that. The world at large, the existence at large isn't malicious. It's more likely, what's the word? Indifferent. Bad things are going to happen in the future, and good things are going to happen in the future, and it isn't entirely outside of my control. I do have some capacity to influence what happens in the future. I can't influence everything, but I can influence some things. I can reduce the likelihood of something bad happening. I can't eliminate it, but I can reduce it. So this is kind of almost like this understanding of the cognitive triad is kind of giving you, underlying anxiety in this case, is giving you kind of the recipe, so to speak, for how to go about cognitive behavioral treatment of anxiety and of depression and so on and so forth. Okay, so these erroneous automatic thoughts, these schema that are characterized by the cognitive triad that we were just talking about, the faulty assumptions about ourselves, our world and relationships, and our futures are sustained, exacerbated by what cognitive behavior therapists call cognitive distortions. And these are essentially fallacies in the sense of a logical fallacy. They're faulty thinking that tends to sustain these fundamental perspectives, beliefs, schemas. So in the sense of somebody who is anxious and has a cognitive triad consistent with anxiety, we're talking about things like experiencing some negative event in their life, minor or fairly significant, and perceiving that event as essentially representative of everything to come. You know, one bad thing happens, and the person ends up catastrophizing and making the assumption that it's going to be worse and worse and worse from here on out. And the term that we use for that is arbitrary inference. We're jumping to conclusions based on very limited data. And related to the idea of arbitrary inference, you also get people sometimes selectively preoccupying themselves or selectively abstracting particular details of a situation. The anxious person, particularly somebody who's struggling with social anxiety, meets a new person and walks away with the assumption after a brief interaction that the person doesn't like them, and the basis for this interaction, or for this assumption, excuse me, is that they didn't make good eye contact. They wouldn't look at me. And you start to, if you're in the course of cognitive behavior therapy, one of the things you want to understand is what exactly was going on in that interaction. And so you'll ask them things, about, okay, well, what was said between the two of you? And they lay out a fairly benign conversation, and and this was at a party, and the beginning of the conversation and the end of the conversation, the person shakes their hand and says, "It's nice to meet you." Perhaps even leaves with some sort of nice parting statement about looking forward to seeing you next week or at some point in the future. And as you go through this kind of recounting of the interaction, it becomes very apparent that the selective abstraction, the preoccupying focus on one detail, lack of eye contact, was not in fact a good indicator for the quality of the interaction. And somebody who has problems with anxiety or problems with depression, what's driving it would be different in each case. Anxiety, it would be that this person is somehow initially hostile to me in some way, doesn't want to interact with me. In depression, it can be similar, but a slightly different quality to it, slightly different smell to it, I guess you could say, in the sense that the depressed person would be more focused on a sense of inadequacy or anticipatory rejection. So you get these cognitive distortions. I mean, and a lot of these are pretty self-explanatory. Overgeneralization, magnification, which is not dissimilar to the idea of selective abstraction. Magnification would be blowing up maybe a small comment or one negative interaction in the course of a week of relatively neutral or positive interactions with somebody, and they focus on just the one bad, the one point of conflict. Minimization can be that a person isn't taking something seriously enough, but it can also be, say, in the case of somebody who is struggling with depression and has the classic cognitive triad of somebody who's depressed, anticipating rejection and so forth. And you begin to go through with them and ask them questions about the factors underlying this anticipation of rejection. And what becomes apparent fairly quickly is, you're dealing with this depressed person, and they're a generally fairly attractive person, both in terms of personality and in terms of physical attractiveness. And you make the point to them that this is indeed the case, that they are that they would be kind of objectively regarded as somebody who is a relatively attractive person. And the response to that from this depressed character would be some combination of minimization and magnification. Oh, well, my ears are too big, or my nose is too big, or I have freckles or bad hair, or something. They take one feature and they magnify this one negative feature, discounting all of the rest of what might make them physically attractive or attractive in terms of personality. Or minimization. Somebody who perhaps is just of average or neutral physical attractiveness. They're not ugly, they're not attractive, but they're really just a likable person. And you begin to explore that with them, and their response to it is, well, nobody cares about that. They're focused on more superficial things. So they're minimizing what is actually a fairly important detail. Personalization. One of the things that you spend a lot of time in psychotherapy talking to people about, whether it's anxiety, obsessive compulsive problems, depression, PTSD, whatever. One of the things that we struggle with frequently, or most of us, is personalization. Generally speaking, especially if you're dealing with strangers, and you're being a reasonable person, you're not being unpleasant, you're not being hostile, you're not needlessly provocative in your appearance, or so on and so forth. You're in the grocery store and the checker is rude to you, and we get it's a pretty common sort of a reaction to get very upset and irritated with this, and to take this personally when in fact a checker, as you're checking out in the grocery store, before you have the chance to say or do anything being rude or hostile to you, probably has very little to do with you. But of course, the person we were just talking about, the depressed character, is going to make the assumption that it is personal, that this person somehow has perceived them in the way that the depressed person perceives him or herself, and is responding appropriately. And then, don't make the presumption that as we're talking about these cognitive distortions that we're hitting on all of the possible cognitive distortions. Much like when we were talking about defense mechanisms in psychoanalytic or psychodynamic psychotherapy, I'm giving you some examples of common ones, but this is not all of the distortions that you end up dealing with in cognitive behavior therapy. So I'm going to leave it at that, and I am going to jump forward to just kind of give you the summary. So what we're talking about here in cognitive behavior therapy then is helping the patient identify and recognize the erroneous automatic thoughts that underlie the schemas, the perspective, the way they think about themselves, their world, and their future. Identify the behaviors that are associated with, how are you acting out in the world, these erroneous automatic thoughts, these schemas. So understanding what is it that you're actually doing in conjunction with how you understand yourself, your world, your future, and then how does this way of thinking and this way of interacting with your world end up making you feel? So helping the patient develop a good picture of this, and then using various techniques, helping them identify the cognitive distortions, using Socratic questioning and other similar approaches. We're going to talk about some of them here in just a minute, to help them identify rational responses to these erroneous automatic thoughts. So we're teaching them basically how to argue with themselves when they are bringing up misleading, false, erroneous ideas about themselves, the world, the future. We're giving them ammunition, so to speak, to have a successful argument against this, how to counter these poisonous thoughts. And then we are working with the patient to identify behaviors inconsistent with whatever these erroneous automatic thoughts are, and getting their agreement, behaviors that are inconsistent with the erroneous automatic thoughts and consistent with what appears to be healthier thinking, and then getting their agreement to actually go out into the world and implement these things. So this would be somebody who has some significant, this is not unusual, by the way, somebody who has fairly significant social anxiety, and is by and large, you're interacting with them, and by and large, they're an attractive person. They're a likable person. That the social anxiety is not firmly based in is not originating from reality-based problems. That it is an erroneous automatic thought, or some erroneous automatic thought and cognitive distortions that are leading to this. So one of the things we might do in that situation is help them come to recognize that the anticipation of catastrophe that underlies anxiety in interactions, in terms of what's going to happen in the future, is unlikely given these objective qualities about them in terms of their physical appearance, interpersonal skills, et cetera, and perhaps we're doing some kind of practical work with them to teach and foster improved social skills, role-playing things, giving homework assignments where they're going to go out and practice certain behaviors. And of course, if we have good reason to believe that they're actually more effective and likable people than they give themselves credit for being, one of the things might be role-playing and then assigning social interactions that are likely to end well. And doing this gradually over time and expanding it to give them some experiences that are inconsistent with their assumptions in the hope that will eventually extinguish those faulty assumptions. So that's the basic. I mean, I'm oversimplifying it, and I'm compressing, cognitive behavior therapy. To learn cognitive behavior therapy is a fairly long process, and there are many books written about it. So keep in mind, we're compressing into an hour and a half, hour and 45 minutes probably, something that's actually a fairly complicated process. Of course, I think I may have mentioned this earlier. Of course, as we're talking about all of this, bear in mind that cognitive behavior therapy, just like existential psychotherapy and psychodynamic approaches, and even behavior therapy at this point, has integrated all of the common factors stuff that we've spent so much time this semester talking about in terms of empathy, congruence, and a sense of genuineness from the therapist, unconditional positive regard, active listening, et cetera, et cetera. The other thing that it's implementing, which is not surprising given the fact that it is fundamentally based on behavior therapy, is that antecedents, behaviors, consequences, behavioral analysis kind of model that the behavior therapy uses. But now, rather than just occupying the therapist just occupying himself, herself, and the patient with the behaviors themselves, although we're still concerning ourselves with that, we're also looking at what are the thoughts, what's the thinking underlying these behaviors, what's the thinking associated with these behaviors. So we're attacking something not just on the front of behavior, but on the front of behavior and cognition. The idea being, it's kind of like using therapy and medicine rather than just using one or the other. We're increasing the likelihood of success if we're changing the way the person, helping the person consciously, intentionally change the way they're thinking about themselves, the world around them, and their future, and getting them to implement behaviors that are inconsistent with the erroneous thoughts about themselves, their world, and their future. Okay, so we're going to spend the rest of our time on cognitive behavior therapy talking about particular techniques that are used in the course of the overall method. So I'm going to basically jump from technique to technique and kind of give you a general impression of how it fits into the overall picture. One of the core techniques is just general goal setting, and kind of in conjunction with the use of homework, self-report measures, these kinds of things. The goal setting tends to be structured in very objective terms. What we want, or generally what we're talking about is, when we talk about goal setting, is we're talking about identifying specific behavior change that we want to see. So something that's observable and measurable, concrete, something that preferably is a fairly easy thing for the patient to keep objective track of. And that is usually part of the homework, is we're actually recording implementation of particular behaviors. Obviously, we want to make whatever the goal is, say in the case of somebody with social anxiety, where they are self-isolating, we might structure goals around ensuring a certain number of social interactions with acquaintances and with strangers on a daily or every other day or weekly basis. We might want to establish a certain amount of outings of certain durations to get them out of their houses, this sort of thing. So observable, measurable, specific, concrete. We want to make sure that whatever we set up for them, for the patient, well, one, it's not us setting it up for them, it's us setting it up with them. And we want to make sure that the patient perceives whatever the goal is as being something that they can actually achieve. We don't want to set up goals where there's a significant risk of failure simply because that tends to disrail the therapy. What you want to do is set very achievable goals that are generally successful. And once you succeed in that goal, okay, then we increase the rigor of the goal in some way, and we gradually move them along in what the behavioral folks call successive approximations of a desired behavior. So if we want the person to be out and about and friendly and social, then what we're doing is, rather than looking for everything at once, we're looking at gradual movement, gradual establishment of behaviors that are closer and closer and closer to that eventual long-term desired behavior. And that is part of the deal, is that we're looking at where do we want to end up. So we get a long-term goal, and then we're taking that long-term goal and going, okay, what are the ingredients to this long-term goal? What do we need to establish? And so we're looking at let's build toward this long-term goal by helping the patient achieve the steps in that direction, the subset behaviors. Yeah, so that's about the long and the short of it. One of the things that sometimes does happen with people coming into therapy, coming into a new therapy, especially if they've never been in therapy before, it's not unusual for the person to come in some degree of crisis, where things have really deteriorated fairly significantly, in which case the goal setting may have to be prioritized. You may have a discussion with the patient about, okay, what's the biggest problem in your life? Or conversely, you may look at improvement in which area is likely to lead to the most significant diminishment in suffering. And I'll tell you just a real practical piece of advice as far as this kind of psychotherapy is concerned. I know I sound like a broken record, but the place I usually start with a patient is with some combination of sleep, diet, and exercise, simply because these are concrete. We know very well how to improve their circumstances in terms of sleep, diet, and exercise. They're very easy to establish as progressions. In other words, maybe we start with sleep hygiene, and we very gradually help the patient improve their behavior around sleep. In terms of diet, maybe what we do is we have them reduce the amount of calories that they're taking in liquid form. Switching from regular to diet soda, switching from whole cream to half and half in their coffee, reducing the amount of sugar in their coffee or their tea, or switching to non-calorie sweeteners. If they're completely immobile and not exercising at all, we set very, very manageable exercise goals, which at first may not even actually be exercise. It might just be getting them to download an app on their phone that allows them to track movement, and with the goal of just increasing the steps daily. One, we want to make sure we're giving them things that are concrete, objective, achievable. We want to look at things that are the biggest bang for the buck. What are we going to get the most improvement out of if we can fix these things? as a way of kind of giving us some basis for organizing our approach, especially when somebody comes in and they're just a mess. They're just having so many different problems. And the nice thing is that if you do that, if you come in and you can get some improvement, you can get the person feeling better by doing something like simply improving their sleep hygiene, getting them moving around, just kind of incidental background activity, not actual formal exercise. And then, if a person's dietary discipline is really poor and they're taking in a lot of liquid calories, you can buy somebody a 5 or 10 pound weight loss over time just improving their sleep, reducing liquid calories, and increasing incidental daily movement. You get them 2, 3, 4 weeks in, they've lost 10 pounds, their energy is better. Obviously, if you're moving around on a daily basis, it's going to reduce your anxiety a little bit, it's going to improve your mood a little bit. And we haven't done anything at that point in terms of goal setting that's kind of traditionally thought of as psychotherapy. And we've created some momentum so that we get better buy-in as we move into things that are a little more difficult and a little more challenging as far as getting the patient to cooperate and institute behavior change. So, goal setting. Another of the basic techniques that we tend to see used in cognitive behavior therapy is what we call cognitive rehearsal. And this is something we use, say, I was talking to you a little while ago about social anxiety, or marital conflict. A real common thing for people to present for psychotherapy, that they're having problems in their marriage, they're fighting all the time, their spouse thinks that they're a grump and unpleasant, or just flat out an a-hole. And so in that situation, perhaps what we would do is, okay, tell me about one of the recent times where you had a big blowout with your spouse. And we get the patient to recount this in some fair degree of detail, so we get hopefully a reasonably accurate picture of what actually transpired. And sometimes we actually even bring the spouse in and get their input on what happened. And then this is partly just skills training and partly problem solving. We look at what went wrong in this interaction. We teach the skills to counter that, so there might be basic conflict resolution, appropriate assertiveness, healthy assertiveness training kind of stuff, basic stress management, anger management kinds of things. We might do some role playing where the therapist, maybe initially the therapist plays the role of the patient and the patient plays the role of whoever the antagonist was, in his or her spouse, and we go through a similar kind of argument and we model for the patient, how to go about responding in a healthier, less provocative manner. And then once the person gets a good flavor for kind of the tone, say in this situation, what we might have them do is go do some relaxation breathing, kind of the cubed breathing kind of thing that we talked about when we were talking about behavior therapy, and then we would have the person kind of go in a nice and relaxed state, go over the kinds of conflict that has arisen and how they're going to respond differently in future instances. And we're talking about this in terms of marital conflict, but it can be the same thing in terms of social interactions that are anxiety provoking for somebody with social anxiety. Smoking cessation, implementation of improved diet. How do you resist the urge to break a diet, et cetera, et cetera, et cetera. The cognitive rehearsal is basically useful for any situation in which the person has found repeated failure in stressful or complicated situations. So basically, what we're doing is we're implementing problem solving, and we're having them practice it abstractly before they actually are in the concrete situation that they have to perform. Okay, and then validity testing. We've already I've kind of talked around validity testing earlier in this lecture. But this is one of those things that we're using that Socratic questioning to address. Essentially, what we're doing is when we have identified whatever the erroneous automatic thoughts are, we're asking the patient to account for them, to defend these beliefs, and then we're asking the patient, say the patient is somebody who struggles with depression, and one of their automatic erroneous beliefs is that nobody likes me. What we might do in that situation is begin to ask them to be accountable for evidence associated with that. What is the evidence that nobody likes you? Is there any counter evidence? Is there any evidence that there are some people who do like you, even if it's not total and complete, even if it's just that there are some people who appear sometimes to like you or want to be around you? And hopefully what we identify is that, and this is usually pretty easy, especially erroneous automatic thoughts are often categorical. Nobody likes me. I never get invited places, et cetera, et cetera. So they're actually usually they're stubborn in the sense that the person is so practiced at them, and they have become so much a part of the fabric of the person's life that the person is really reticent to let go of them. But on the other hand, oftentimes they are clearly irrational. And if you can work your way methodically through them, you can identify evidence that they are objectively irrational. And then what we're doing with this validity testing is this automatic erroneous thought? Is it valid? Is it actually true? And if we can identify some evidence in opposition to it, evidence that the patient is willing to endorse, is willing to accept, then what we've done is we've given the patient something to combat that erroneous thought. And the more evidence we can marshal against the erroneous thought, the more tools we're giving them to combat it. A similar intervention, a similar cognitive behavioral technique is what we call guided discovery. And this is essentially the CBT term for Socratic questioning, and it's basically we're asking questions exploring whatever the problem area is. We're using the basic active listening, reflecting, to ensure that we're understanding what the person is saying, and then eventually summarizing what it is that they are saying to make sure that we're getting it right. And then it sometimes just the course of that ends up being fairly good evidence. This can actually be part of validity testing. As we summarize what the patient is describing, the patient hearing it from somebody else's mouth recognizes that, hey, this is nonsense. This is not accurate. This is not the way the world works, et cetera, et cetera. And then, of course, once we have a good picture of guided discovery is one of the techniques that we use for understanding exactly what the erroneous thought is, for example. And when you identify that, then you're connecting it with, okay, so you have this picture you painted for me, and it appears to be related to the problems that brought you in this way. Because basically this is kind of almost like the insight-oriented part of cognitive behavior therapy. We're helping the patient understand exactly what is causing the problem for them. And the thing is that they are the ones guiding it, really. We're just asking questions. They're the ones that are laying it all out for us. All right, journaling. Um, this is essentially a homework technique that we use um, to get the patient to be thinking actively in between sessions. Journaling is wonderful for this. Uh, I think I may have talked to you about this a little bit when we talked about behavior therapy. Um, One of the limitations of psychotherapy is practical, that it is limited. That we're seeing the patient for perhaps an hour a week if we're lucky, and in all likelihood less than that. Um, and so we're looking for strategies to keep the patient focused on the problem solving, on making behavior changes outside of just the hour or so that we get to spend with them weekly or bi-weekly or a couple times a month maybe. Uh, if the only time they're really thinking about the problems that brought them in is during the actual hour of psychotherapy or 50 minutes of psychotherapy every other week or something like that, the odds that we're going to make significant progress are very small. On the other hand, if we can establish something that makes them think extensively about the problems on a daily basis or multiple times a day, the odds of getting improvement increase significantly. And so basically what journaling is that it's a version of that antecedents behavior consequences model that the behavioral approach uses. But what we're asking the patient to do is to document the to identify and document a precipitating event and the automatic thoughts that are associated with it. So something caused a problem for them, something happened and it caused trouble. And we're asking them to identify it, identify what then went through your head. What was the automatic thought? Because we're wanting them to pay attention to that. We're wanting them to recognize these erroneous automatic thoughts so that they can be countered. And then we want them to document. And actually, when you do this journal, you actually might have listed out on multiple pages A, B, C, D, and they actually have places to fill this stuff in. What's the activating thing, the precipitating event? What was the associated automatic thought? And then what then happens cognitively? Where does your brain go? What is the negative thinking that then is subsequent to that precipitating event? Where do you take yourself? And then what are the consequences of that automatic thought, the subsequent thinking, the beliefs? What ends up happening? What kind of emotional state does it create? What kind of maladaptive behavior does it produce? What are the consequences of that negative, erroneous automatic thought? And then what we want to do, and this is really the therapeutic part of it. Well, not that stuff isn't therapeutic. It's good. They're catching this stuff. They're recognizing it either as it's happening or immediately thereafter. They're recognizing, man, there's a cost to this. It is causing problems in my life. But then what we want them to do is we want them to dispute the erroneous thought and the associated beliefs. So we're basically prescribing, so to speak, the person to act in their own best interests, to have that argument, that healthy argument with themselves about the negative and presumably false beliefs that they're carrying around. So we're asking them to identify alternative ways of thinking, and generally speaking, the alternative ways of thinking have been identified previously for the patient in the psychotherapy session. This is part of that guided discovery, Socratic questioning, all of that sort of thing, the validity testing, that sort of stuff. So they've already kind of got their ammunition, they've got their tools, and they're catching the automatic the erroneous thought, the cognition and maladaptive behavior that follows it, and then we're asking them very quickly after that's happened, or even in the moment sometimes, as the therapy progresses and they get better and better at this, to consider the alternatives. What else? How else could I have thought about this? How else could I have responded? And then we ask them, not infrequently, to actually counter the negativity by recording something in opposition to it, something positive, some affirmation. And then we ask them to identify how they're going to support whatever this positive thing is. And this might be, I'm gonna take a different action next time in this way. I'm gonna do something different next time in this way. And then we also ask them to, if this process has helped, if they feel better, say, then we ask them to document it. If they have success later in the day, or the next day, and they respond better to an automatic erroneous thought. Perhaps the erroneous thought arises and it's normally followed by some problematic behavior, but they're able to intervene, stop that behavior, and do something, produce an alternative behavior that's more productive, and they're actually successful at it. We get them to document that. So they come into the psychotherapy with a little workbook of things. Of this is how things have gone over the course of the week, and hopefully what we see is we see progress that leads to kind of an accumulation of momentum in the right direction. I don't know how much I'm really going to say about this because I've already kind of talked about it. This is basically a version of rehearsal, modeling desirable behavior, and then role-playing the behavior. It's a technique of rehearsal. Like I said before, sometimes the person comes in and what you're asking them to do, say somebody who's socially anxious, and you're asking them to respond in novel ways in social situations so they get a better response from people. Perhaps at first you might want to role model that. This is how you respond. And then you might shift from modeling it for them to role playing it, so the initial modeling might be, okay, you be the checkout person and I'll be you, and we'll go through how you make conversation with somebody. And you might even encourage them to be as difficult as you are worried the situation is going to be. So we might ask them to actually to be unrealistically provocative or difficult. Hopefully we have the capacity to respond effectively to that. And we're demonstrating them, we're modeling for them, how do you respond in this difficult situation, this anxiety-provoking situation? And once they get a good handle on it, we begin role-playing, so we reverse it, and we let them take over and begin to practice some of these skills that we're teaching them. And we might do this many, many times before we actually send them out into the real-world situation where we're going to ask them to practice these new skills. Homework. This can include the journaling that we were just talking about. This is basically just asking the patient to do things in between sessions. So this might be journaling. This might be going out and implementing things that we have been role playing. It might be for somebody who has social anxiety. It might be something just as simple as, I want you to spend X amount of time in the grocery store or in Home Depot or in Walmart or wherever. And again, just like with journaling, part of the purpose of role modeling, part of the purpose of homework is to keep the patient thinking about and taking action on whatever the psychotherapy is focused on in between sessions. And then the last two things I want to talk to you about, the first of those last two things is aversive conditioning. And this is basically, I'll give you the classic example that we use. This is almost a cliche at this point. We might, a person who's trying to get rid of a relatively minor, fairly concrete problematic behavior. They're trying to give up smoking. And we wouldn't just use this for giving up smoking. Obviously, we might use nicotine replacement or a patch or something like that. We would probably prescribe incongruent behaviors that are inconsistent with smoking. Some basic stress management, relaxation, breathing, this kind of thing. So we're doing a variety of things. But one of the things we might want to do is that when they have the urge for a cigarette, we'd have them put a hair tie or a rubber band or something around their wrist. And then when they think about having a cigarette, or they have an urge for a cigarette, we'd have them just pull that rubber band out and let it go. And basically they're snapping the inside of their wrist. Again, this is kind of a cliche, but it actually does work. And the idea here is we're using aversive conditioning to reduce the frequency and the intensity of problematic thoughts. We're in the language of psychodynamic psychotherapy, we're trying to make ego dystonic a certain behavior or a certain thought. We're trying to make it something that the person sees as no longer part of their identity. One of the other ones that I like to use is with somebody who has problems with anger management. I get an agreement from them to practice genuine, profuse apology. So if they're irritable, say we got a guy and he's a grump and he's a jerk to his wife. In my practice, it's often because they have PTSD. For the guys who come in and they really are genuinely tired of being a jerk at home, what I might have them do, men tend to be very bad at this, is we get them to agree. Okay, so next time you're grumpy with your wife, as soon as you recognize it, you're going to make a perfect apology. And a perfect apology, I prescribe this for him, and we role play this, we practice this. They know that a good apology is, I'm sorry for whatever that was that you did. I'm sorry for being rude to you, and then identifying explicitly and concretely how they were rude. There was no excuse for that. I'll try my best not to have it happen again. And we're coaching them in terms of good eye contact, a voice tone and body language that suggests that they actually mean the apology, and we're prohibiting the use of the word but. And I tell them, that if you make an excuse, if you make an apology that involves the word but, it wasn't an apology, it was an excuse. So they don't get to say, I'm really sorry for being grumpy with you, but you made me mad, but none of that. None of that. Abject apology, without reservation. We practice it, we role play it. This is a version that, one, we're substituting desirable behavior, right? If you're a jerk to somebody and you make a good apology, it's probably going to help the relationship. But the other thing is that it really does involve eating crow, which is very hard for some people. I find that it tends to be even harder for men. Men are really, really reluctant to do this. And if you can get them to begin implementing it on a regular basis, it counters the irritability, because they so want to avoid having to eat crow. They so want to avoid having to, in their way of thinking about it, grovel and seek the apology. And one of the things that's nice is that you can often get a buy-in, because it actually becomes kind of humorous, because it's just so noxious to them. They just so don't want to do it. And recognizing that, yes, this is difficult. Nobody likes this. But the other piece of this that's kind of nice is, initially it's aversive. Initially they try really hard not to be grumpy, because they really don't want to have to make this kind of apology. But then the cool thing about it is the other thing that arises is they find out that it actually isn't that bad. We walk around and we're reluctant to admit to somebody when we're wrong, and we're reluctant to admit to somebody when we've really been a jackass. But then once you've done it, and you tend to get in most cases, you tend to get a fairly positive response from the person who's grateful for a genuine apology. is that you find out that making a genuine apology, accepting responsibility when you've done something wrong, actually isn't catastrophic. Nothing terrible is going to happen. That's often a novel experience for the person, and they have to actually go through it several times before they recognize this, and then it becomes not so much aversive conditioning, but a new social skill. And then the last thing keep in mind, I'm talking about some of the CBT techniques. We're not talking about anything remotely approaching all of them. I'm just giving you some examples of some of the major ones that are used that kind of together comprise what we do in cognitive behavior therapy. But systematic positive reinforcement, kind of the opposite of aversive conditioning. We often use aversive conditioning and systematic positive reinforcement with kids. We can do it with a token economy. Say, for example, you want a kid to, you're trying to replace some problematic behavior for which you're using aversive conditioning with something positive. So when we do get the positive behavior that counters the negative behavior, we want to reinforce the positive behavior. So we might do that by, say, like with a kid, we might make up a chart that goes on the refrigerator, and every time they do, every time they, I don't know, they pick up their room, or they help with the dishes, or they take out the garbage or whatever, they get a token, they get a sticker, and then if they accumulate enough stickers, they can redeem these stickers for some reward. Maybe it's actual money, maybe it's an outing, maybe it's something special for them. And the reality is we do this frequently with kids or with adults who have developmental disability or are living in residential settings, supported living settings where they have staff that are working with them. But we can also do this ourselves. You can get an adult to implement these kinds of things themselves. Is that when they've teaching them to reward themselves, and it can be something as mundane as I have a good one with exercise, because exercise is so effective at countering anxiety and depression. If we can get them exercising fairly vigorously on something approaching a daily basis, we're going to get improvement. So perhaps what we would do is we get them to download an app that that prescribes certain workouts. And that when, on a day that they achieve a particular intensity in one of these workouts, and some of these workouts can be pretty brutal, that we set a certain standard, and if you reach standard 1, that the exercise got your heart rate over this amount, kept it there for this amount of time, and produced sweat, that you get to reward yourself, or if you go to level 2, that it actually, that it involves some sort of high intensity interval training that you sustained, that maybe you get to go out and celebrate that with, I can tell you for me, on good workout days, they're followed by a beer. And that sounds silly, but if I get to go celebrate this unpleasant thing that I have to do or I should do by doing something that I really enjoy. If you make doing the thing you really enjoy contingent on doing the thing you don't really want to do, you're much more likely to go do the thing you don't really want to do. And that's just systematic positive reinforcement. So I'm going to stop here because we're already 2 hours in, so we're approaching a normal class length lecture. I did get you out half an hour early, so that's good. Just a reminder, if you made it this far, make sure you're reading the book, make sure you're going over the PowerPoints, and make sure that you are watching this lecture. I will hopefully post another lecture early this next week. I'm going to try to do a couple of them next week to get us a little bit more caught up. And in the coming week, I'll probably begin to talk to you a little bit about the exam upcoming and how we're going to approach that. All right, I hope everybody is well and safe, and I will talk to you next week. Send me an email if you need anything, and like I said, stay well.